Hello, my name is Gilberto Castro. I am a medical oncologist here in São Paulo, Brazil. I am a professor of clinical oncology at the University of São Paulo, and I am also a medical oncologist at the Hospital Sírio-Libanês in São Paulo, Brazil. We are now very proud and very happy to inform you and to discuss with you some of the results of the ADAURA trial that were presented in the ESMO 2020 meeting. Today, we are very pleased to have with us in this presentation, in this discussion, Professor Masahiro Tsuboi, the director of the Division of Thoracic Surgery in the Department of Thoracic Oncology at the National Cancer Center Hospital East in Chiba, Japan. And also we have with us Dr. Guilherme Harada, a medical oncologist of the Oncology Center of the Hospital Sírio-Libanês. Hello, Professor Tsuboi. Hello, Dr. Harada.
Hello. Thank you very much for the introduction.
Hello, everyone. It's an honor to be part of the discussion with our friends of Onconews, Dr. Gilberto de Castro and Dr. Tsuboi.
Okay, so I think we can start. First of all, Professor Tsuboi, we would like to congratulate you and all the investigators for the impressive results of the ADAURA trial, a practice-changing study published yesterday in the New England Journal of Medicine, just after your presentation in the presidential session of the ESMO 2020. In addition, the US FDA has recently granted a breakthrough therapy designation to osimertinib for the adjuvant treatment of patients with stage 1B, 2, and 3A EGFR mutated non-small cell lung cancer following complete resection with curative intent, based on the ADAURA results. However, and probably you will agree with me, there are some relevant aspects in the clinical daily practice that remain unanswered. The first aspect is related to the chemotherapy, the adjuvant chemotherapy. In your opinion, in these patients with stage 1B, 2, and 3A, EGFR mutated non-small cell lung cancer following complete resection with curative intent and based on the ADAURA trial, is there still a role of the adjuvant cisplatin-based chemotherapy in which patients?
First of all, I'd like to thank you for the great invitation. So it's a great honor to have a chance to discuss with you. The first question, as for the first question, please understand that the design of this study was not set up the identity of the role of the adjuvant chemotherapy for EGFR mutation positive patients in the first place. The design that directly compared EGFR TKIs and chemotherapy, such as adjuvant or Ceton 1104, might have answered that question. The following data has been demonstrated in our New England Journal paper, and more detail for these issues will be presented in the World Congress of Lung Cancer in the next January. Adjuvant chemotherapy used before randomization in ADAURA was consistent with the uptake of the practice in the community. For example, in Japan, we didn't enroll the patients because we do the UFT adjuvant in the patient with stage 1B, and we don't do adjuvant chemotherapy in the clinical practice for elderly patients over 75 years old. The majority of the stage 2 and 3A patients and around a quarter of the stage 1B patients received the adjuvant chemotherapy balanced across the arms in ADAURA study. The disease-free survival benefit with osimertinib was observed irrespective of whether patient received the adjuvant chemotherapy or not. Of course, who received the adjuvant chemotherapy, 89% with osimertinib versus 49% with the placebo were alive, and disease-free survival, disease-free at 24 months. Of patients who did not receive the adjuvant chemotherapy, 89% with osimertinib versus 58% with the placebo were alive, and disease-free at 24 months. Disease-free survival hazard ratio was 0.16 and 0.23 in the patient without adjuvant chemotherapy, respectively. That's my
Okay. Okay, thank you. The second question, Professor Tsuboi, and according to the ADAURA design, patients received osimertinib or placebo for 3 years. Why the decision of these 3 years? And I think it's important, and could you comment on the treatment duration, taking into account that adverse events of grade 3 or higher were reported in 68 patients, or 20% in the osimertinib group, and the incidence of all-grade diarrhea was 46% in the osimertinib group. Could we have your comments on that?
Yeah, very excellent question. The planned treatment period was 3 years based on the observation from the literature on the recurrence dynamics, showing that the majority of the recurrence occurred in the first 3 years of the treatment after resection. Although the most study, actually the majority means that 90%. Although the most studies investigate the adjuvant EGFR TKIs in the rejected setting have applied the treatment period for 2 years. Historically, examples of the target drugs used in the treatment of the other solid tumor, such as the hormone receptor positive breast cancer and the GIST, have demonstrated a longer duration of adjuvant treatment to be assisted with improving outcomes. The safety profile of the osimertinib makes it feasible to aim for the longer treatment duration than the 2 years, and such as the period 3 years were selected. As for the safety data in the current results, adjuvant osimertinib has a low frequency of dose modification and discontinuation reported has no new safety concerns based on the established profile. All interstitial lung disease events were mild and moderate in severity and generally considered less clinical severe than the previously observed in the metastatic setting, with patient recovery reported in all cases. Furthermore, no notable differences between the treatment arms were observed in relation to the cardiac adverse events.
Okay, thank you. The next question will be made by Dr. Guilherme Harada. Guilherme.
I would like to ask you, Dr. Tsuboi, about the cell-free DNA monitoring and minimal residual disease, or MRD. Follow-up assessments were performed at weeks 12 and 24, then every 24 weeks in patients included in the ADAURA study. Could you comment, please, Dr. Tsuboi, on the cell-free DNA monitoring of these patients? Was this biomarker studied?
Very good question, but we didn't do that. So ctDNA monitoring in this trial. But actually, this moment we don't have data for on the ctDNA. But we are taking blood samples every 3 months at visit, so we expected to be able to show that the data after OS data becomes mature.
Thank you. And another important issue, and actually a provocative question, is the initial staging of the patients in the trial. According to the protocol, baseline brain MRI and PET-CT were not mandatory procedures, and some patients might have entered into the study with metastatic lesions. Could you comment on this aspect? How could this issue influence the results?
Yes. So actually, in ADAURA, MRI and CT scan of the brain was required in all patients prior to surgery or randomization. to be precise, there was a lead time bias in the baseline, but we evaluated CNS metastasis at least once before randomization. In my clinical practice, almost all patients were evaluated for the CNS metastasis before surgery, and in cases where this was not done, MRI or CT was done before post-operative adjuvant treatment was given. Since this study in the phase 3 trial, I think it is sufficient to evaluation to the CNS in the form close to the actual practice.
Okay, thank you. The last question, Professor Tsuboi, is related to the overall survival results of the paper. It's mentioned in the ADAURA manuscript that the trial was not powered for overall survival, despite one of the objectives of an adjuvant treatment is to prolong survival and to increase cure rate after eliminating micrometastatic deposits. And why not to design a trial with and to detect an overall survival difference? And in case of no difference in overall survival between the two studied arms, can we still recommend adjuvant osimertinib based only on DFS, disease-free survival results? And in fact, a glimpse into the future. May osimertinib at the time of relapse lead to the same overall survival results?
Yes, I think you are correct in your opinion. However, I think that the decision of the calculated sample size from advanced risk data to overall survival would be unrealistic for the company, as the number could be the enormous, very huge. So I supported this idea. The recurrence means that the loss of the chance for a cure. So the prolongation of the disease-free survival and the reduction in the risk of the recurrence metastasis of about 80% are very important information for the patients who are expected a cure. In clinical practice, I think the final decision on whether or not to use adjuvant osimertinib should be made after considering that the risk-benefit balance, including the cost of toxicity in each patient. But anyway, I would like to emphasize the prolongation of the DFS is very important for the patient, because if the recurrence occurred, patient lost to the cure chance.
Okay, great. Professor Tsuboi, thank you very much for this interview. Thank you very much for your time for the discussion. Again, congratulations for you and for all the investigators of the ADAURA. As I mentioned before, it's a practice-changing study, and probably it will generate lots of discussions, not only in the following months, but I think in the following years. Again, thank you, congratulations, and Guilherme, thank you also for your participation. And thank you for all of our colleagues that are following us, and thank you for you also for your attention, and please continue to follow our coverage of the ESMO 2020. Bye-bye. Bye-bye.
Thank you very much. Professor Castro, may I ask you a question? May I ask one more additional comment for the
yes, sure.
overall survival results?
Yes.
So if you look at the result of the adjuvant CETON 1104, there are those fears. At the moment, no one knows that the answer to your question. So personally, I think that it's important to know that the cure rate at 5 years after surgery or randomization, how many people remain treatment-free after adjuvant treatment is completed. The prognosis is also expected to differ depending on the mode of the recurrence or metastasis, such as whether it is a single tumor, oligometastasis, or multiple mets, and whether it is a single organ or multiple organ mets. We will await the analysis regarding the sequential treatment with great interest.
Yes, I completely agree with you that the pattern of recurrence will be very interesting to be studied. In the paper and in your presentation yesterday, you have shown that there are, in terms of frequency, not in terms of numbers, in terms of frequency, those patients treated with osimertinib presented higher rate of local regional recurrence, and on the other hand, patients treated with placebo present, in fact, more a higher frequency of metastatic recurrence. So, as we can, after following these patients more and more, probably we can detect some patterns of recurrence. And I fully agree with you that some of these patients will be good candidates for local regional therapies. And they can also, at least in theory, can be cured. So, and so we need to wait. And as Professor Vanterskit yesterday commented, we need to be patient now, to have patience for the patients. So let's wait for the future. Okay. Do you have any more comments or any other question?
No. Yeah. Thank you very much.
Okay. Thank you. Guilherme, any other question or comment?
I would just like to thank you, Onconews, you, Dr. Gilberto, and Dr. Tsuboi for this amazing discussion.
Okay, great.
So I directly meet you again in directly in the Congress in the next year or something.
Yes, let's wait for the vaccines, and I hope that we can meet each other in person, at least in ASCO, in ESMO, and probably in the World Congress of Lung Cancer. Great, great.
Yes.
Okay, thank you. Bye-bye.
Thank you very much. Thank you. Bye. Thank you. Thank you very much.